This
Tonight is
conference will now be recorded.
Our speaker tonight is John Fortin, who's sort of a man for all seasons in the prostate world. He represents all prostate cancer patients in the United States to the American Urological Association. He happens to be on the board. He's newly named to the board of US2. I don't know. He's got a whole long list here, but he professionally he was sort of well prepared for what happened to him when he got cancer. But why don't you take over, John, and I'll shut up. It's all yours.
And I think we want to move to a view of these slides at this point, if we could, ideally. And if not, that's okay, but we need the slides. Perfect. And we see the bubbles. Thank you, Howard.
You're
I want
welcome.
to thank you, AnCan, ASPE, and of course, I shamelessly will promote US2 tonight. A very proud member of the board, along with Bo and Jim Schrate and Dr. Lawrence Klotz and Stacy Loeb and some really, really good people. Thank you for the opportunity to discuss focal treatment at this virtual support group meeting. I hope everyone can safely stay on active surveillance for many years and avoid any treatment. And I hope that this presentation is thought-provoking and helpful to you. Also, I do apologize in advance for the complexity. Even the best researchers and the FDA are completely perplexed by this topic. So don't worry about all the details here. A key takeaway is from our friends at AnCan. Be your own best advocate. Do lots of homework before making any treatment decision. Next slide, please. Aha, perfect. As you know, I am not a clinician, so anything you hear should be discussed with your doctor. And my training is as an actuary. Who even knows what an actuary is, but I'm a mathematician, and my background is healthcare data analytics, including oncologic outcomes and side effects of various treatments. My avocation is to help patients. That's what I enjoy doing. So I wear many hats as an advocate, coach, and of course, other roles with the AUA. I represent all urological patients in the United States, and I'm a journalist for us to you today. So this is my life. Next slide, please. First, we will take a look at my personal journey with focal treatment back in 2014. But this is just an anecdote of one patient and one type of focal. So in part 2, I will put on my actuarial hat and I'll take a broader look at some other focal treatments. At the end, I'll be pleased to entertain any questions from our audience. Next slide, please. My journey started with my PSA gradually increasing to about 5 when I started getting serious about looking at things. It ultimately reached 6 before treatment. So I declined to have a trust biopsy. Instead, I had some additional blood work and some biomarkers. These indicated I might have a problem. So I had an MP MRI and a targeted biopsy of suspicious areas. I also got some genomics tests of the biopsy tissue. Everything was covered by Medicare. Again, that's without a trust biopsy, it was covered by Medicare in full, contrary to what many people believe. The end result was a total of 3 lesions on both sides of the prostate with low to intermediate disease. Next slide, please. Thank you. I talked with experts who have specialties in active surveillance, imaging, surgery, and radiation. I got second opinions and third opinions. My plan A was active surveillance, but not a single doctor recommended this, including the active surveillance specialists. I had too many lesions and they were located on both sides of the prostate. But plan B was whole gland radiation and surgery. But I found this was not a good idea for me. I looked at, as an actuary, randomized controlled trials, meta-analysis, all the data. And what I found is that neither radiation nor surgery would extend my longevity by much, if any. And the treatment would lower my quality of life, probably by a very significant amount. We sometimes hear about side effects, blah, blah, blah. There are very significant implications of whole gland treatment that people need to understand. Do your homework before you go in that direction. So I had a conundrum. Doctors at 2 centers did recommend focal treatment. Next slide, please. My wife and I had to wrap our heads around a new paradigm. Realistically, focal is more about controlling rather than curing cancer. But there was no guarantee that radiation or surgery would cure it. Studies revealed about a 50-50 chance, that's all, that surgery or radiation would work. In fact, it was likely to recur in 10 years, even if I had that treatment. Now, admittedly, a major drawback of focal was cost. It was $16,000 at the time and might not be covered by Medicare. But if, and I repeat, if it met my goals, this would be the best investment of my life. Now, my goals, and I had to think through my goals. You have to take a fresh look. What were my goals? Number 1, eliminating current lesions. Number 2, maintaining high quality of life. And 3, preserving future treatment options. Focal treatment appeared to check all 3 boxes. Now note, researchers have been trained not to look at it this way. Researchers think you need 20-year outcomes. I didn't need 20-year outcomes. If I could just satisfy myself that over the next 3, 4, 5, 6 years, it could last and meet these 3 goals, then I felt good about that investment. Next slide, please. After a few months of study, I chose to have FLA done at the University of Texas, Galveston. It was an outpatient procedure with just sedation, much like some of you have had with a colonoscopy. FLA is done with real-time, precise guidance in bore, not fusion guidance, which can be off by several millimeters. It is a precise beam with thermometry to protect healthy tissue. Now, knock on wood, 6 years later, I have no evidence of disease or any side effects. My surveillance regime, ongoing, includes PSA every 6 months, MPMRI every 12 to 24 months, healthy diet and lifestyle. Now, Medicare initially turned down the claim, no surprise. I appealed, and an administrative law judge 3 years later ordered Medicare to cover my expenses in full. I was reimbursed my $16,000. There's only one catch. My case is not a precedent for other patients. Now, some other patients have come to me, I've helped them, and they've got reimbursed in full, just like me, through an ALJ. Next slide, please. Of course, as I said before, my story is just an anecdote, but I was curious and I thought it would be interesting to do a survey of FLA patients on my own. I would get feedback directly from patients, not through doctors or other people that, I really didn't know the source of the data. So I went online and did basically a survey monkey approach, and it's a healthcare survey of 100 FLA patients on Euro Today. And it's still there if you'd like to look it up, or I could send you the file. It was published in 2015. I asked patients many, many questions, And in the interest of time, I'll just go over one or two. One question was, what would you have done differently out of the 100 patients? 88 reported little, if anything, would they do differently. 8 said they would have skipped the trust biopsy. 2 said they would have looked more carefully at which radiologist they chose. 1 patient said he would have stayed on active surveillance, and 1 patient said he would have had radiation or surgery. Also, it was interesting to me, I asked the question, would you recommend FLA to a friend? 99 out of 100 said yes, they would recommend it to a friend. Next slide, please. Part 2, we're shifting gears here and talking in a broader sense. Here I'd like to take off my patient hat and put on my actuarial hat, where I'm more looking at objectives, apples and apples, not as a patient, but as a mathematician. So I try to be 100% objective. Focal, first of all, can mean a lot of things to different people. It can mean treating a spot. So in the first picture, you see that red spot, that's the lesion. The white spot is the urethra. So you can treat just the spot plus a little margin, or you can treat a quadrant, or you can treat hemigland, or another shape. It could be a hockey stick. In the case of Tulsa, it's a wedge that goes out, starting at the urethra and going out to the end of the lesion. So it could be a wedge for that modality. Every trial is different, so comparisons are apples and oranges. Some might cover mostly Gleason grade 1, otherwise known as Gleason 6, and others might be mostly Gleason grades 2 and 3. Some trials use mandatory imaging and confirmatory biopsies to make sure the treatment worked. Some trials might have PSA reduction as their endpoint, or metastasis-free survival as their primary endpoint. So some trials even allow hormone treatment in addition to the focal treatment. So when you think about how numbers are reported and all these differences, what you read online or you hear from your friends or you see on websites, you really have to be careful about what you're reading. And a lot of patients, have been hearing half truths, which weren't wrong, but they were really misled. But what they heard from well-informed people who may or may not fully understand what they're saying to patients. With all of this in mind, I would like to share a brief description of a few treatments, and at the end, some trial results. I'll cover Cryo, FLA, HIFU, and Tulsa. Next slide, please. Cryo has been around for many years. It relies on freezing the tissue and is widely used after radiation or surgery fails. It is generally covered by insurance. That's the good news. Ultrasound has been used, in other words, sound waves have been used in the past for not just doing the procedure, but for guidance, although more precise approaches are being tested that are better than ultrasound. While cryo can be used for focal treatment, it is not as precise as other energy sources. I haven't seen any credible trials that report focal cryo's outcomes, including side effects. Now, one reason you don't see any clinical trials on cryo for focal is that it's already been approved by FDA for prostate cancer. So they don't need trials. They get reimbursed without ever doing a single focal study. So that's why I can't analyze it. Next slide, please. We've already talked about FLA. It has been allowed by the FDA in the United States since 2008. The first patient treated was a doctor. The second patient treated was a friend of mine who still has had no recurrence and no side effects since 2008. It's been done on probably 1,500 patients. I don't know how many, but it's a very big number. Its strengths include its ability to treat any size prostate, very specific spots with a precise energy source, excellent guidance, and thermal monitoring. However, it may not be optimal for large spots, including BPH, and it is not available at many locations. Next slide, please. You've probably heard a lot about HIFU. It is widely used in Europe and the US. I believe it's been legal here since about 2015. So you can do it in the United States. Also, it is used typically to treat hemigland areas. It uses a precise ultrasound energy source with fusion guidance, which is less accurate than in-bore guidance. There is, however, an in-bore version of HIFU that reports excellent outcomes. Unfortunately, there aren't many locations in the United States that have the in-bore version of HIFU. Next slide, please. The latest and greatest thing that we're all hearing about these days is TULSA-PRO. It is similar to HIFU in that it uses ultrasound as the energy source. One advantage of TULSA is excellent guidance since it is an in-bore procedure. Other advantages are that it uses devices that cool both the urethra and the rectum, and that avoids collateral damage, so it's good for side effects. It has thermometry that is used to measure temperature to avoid side effects. It uses very sophisticated software. Now, there are some protocols that are being tested that could make it better. These could eliminate or improve the need for an overnight stay in a hospital, anesthesia, suprapubic catheter, and some other disadvantages of this approach. Next slide, please. Now, many of us are worried about cost. These latest treatments are not covered by insurance. So when will the new procedures be covered by insurance? No one knows. I have no clue. The good news is that I'm not going to read this slide. It's way too complex, okay? So don't worry about reading the slide. The bad news is that generally speaking, a new cancer drug or procedure has to spend many years and many millions of dollars to go through all of the hoops, all of these hurdles to get to approval and get to reimbursement. An important step is for the FDA to approve it specifically for treating not just the prostate, but for treating prostate cancer. None of these new approaches are approved by the FDA to treat prostate cancer. Many of you have read something to the contrary. Those people are wrong. They're misinformed. And unfortunately, we patients hear this all the time. It's approved by the FDA. It is not approved for prostate cancer. It won't be reimbursed. So I'd like to kind of pull all of this together and conclude with a summary of some key issues including outcomes and costs. Next slide, please. First, I'd ask you to look at the box in the bottom. It shows the devil in the details. Very importantly, as many of you already know, some doctors get much better results than others. So I don't care if you do whole gland, focal treatment, no matter what it is, find the best doctor you can find, travel to, and afford. If he's done a lot of procedures, you've got better than an average chance that he will do a much better job than the average doctor. And that's very true of focal treatment. Don't go for the low-cost provider. Typically, that could be a mistake. Also, every trial, as I said before, uses different eligibility and how they measure success. So we can't just look at a simple spreadsheet. A researcher would be appalled that I have a spreadsheet in front of you. He or she would take that down. Don't look at a spreadsheet. There's been no level 1 evidence, randomized controlled trial comparing this treatment with that. And the research is true. Nonetheless, I'd like to show you some numbers so you could kind of get the gist of what's going on. So with all of that, please look at the bold row in the middle, and it says Oncologic Outcomes, and that's recurrence. Not just PSA going up, but real recurrence, biopsy proven recurrence. Now, reports show that FLA, now this trial started a little over 10 years ago, so the average follow-up is about 5 years for a given patient. This trial reveals biopsy-proven mandatory biopsies, whether they see it on the MRI or not, they do a mandatory biopsy, that there's a 23% in-field recurrence over about 5 years. It also shows about a 4% new cancer, not in the infield treatment area. So move over to the next column, HIFU. You'll see that HIFU trials, they've been done mostly in Europe, and they're very, very hard to analyze for many reasons. A lot of them include no mandatory biopsy. Some use hormone treatment on some patients in addition to the focal treatment, and there are a lot of other differences. So really you can't compare HIFU with FLA, you really can't, but I'll do it anyway. The HIFU studies report total recurrence, that's all clinically significant and non-significant, on the order of 40% residual cancer after 2 years. Note that the in-bore version of HIFU is only a 9% recurrence, really superior results. The Tulsa US trial showed a 24% incidence of residual disease, that's clinically significant disease after 12 months. Also, an additional 14% had residual non-significant disease, in other words, Gleason 6. So a total of 35% recurrence, proven biology recurrence on TULSA-PRO after 5 years. I'm sorry, after 1 year. 1 year. The new results will be about in a few months, and that'll show the update after 2 years on the TULSA group. By the way, I spent a lot of time with TULSA. I've gotten calls the last 3 days from TULSA patients, 2 who are looking at TULSA, 1 who just had TULSA and it failed. I met today for an hour with TULSA-PRO people, Profound Medical, their top researcher in Canada, and also their salesperson. I was on them online for an hour today. Last week, I went on site to a TULSA installation, and I spent 4 hours looking at how the procedure is done. You know, I inserted the catheter, was hands-on how to do the mapping, how to do the procedure. So I did that for 4 hours last week. So I'm really, admittedly, you know, kind of obsessed with prostate cancer. And, you know, I just want to make sure I understand it before I tell a patient anything about it. So I will report, as shown here, other outcomes vary and are generally favorable. The side effects are good to excellent. Now, some of these columns are better than others, but all of them have very good PSA reduction, metastasis-free survival, overall survival. So the side effects profile is much better than any whole gland treatment. That is true. Now, long-term, the oncologic outcomes are unknown, but, you know, in my case, I really didn't care. I couldn't wait 10 or 15 or 20 years to do a trial. I had to make a decision. You know, it's either treat, no treat. And for me, if I could be satisfied that it might last several years, I was a happy camper. So that was my story. So all of these focal treatments are worth looking at. Next slide, please. At this point, that does conclude my prepared remarks, and I would like to turn the program back to a moderator who will coordinate the Q&A. Thank you very much.
Okay, who's going to jump in? Elliot, Howard, would we? Who's going to do it, or should I take charge here? Tell me. Howard's muted and Elliot's muted, so there you go, Elliot. Why don't you go ahead, Elliot? Jump in and handle some questions. I would suggest that if anybody has a question, there's 32 of you on the line right now. If you've got a question, put it in the chat box. Open up your chat window and put that question in the chat box. We'll watch the chat box. Elliot will read the question. I just want to say that was phenomenal, Mr. Fortin. What a professional. That was such a great job. I also have my suspicions that you might be getting a medical degree on the side so you can do TULSA-PRO before too long. I'm not sure.
Well, I learn a lot from Rick. So I'd like to show you one thing that I learned from Rick.
Oh, thank you. Yes. Thank you. Thank you. That our new AnCan shirts say
Be
be
your
your
own best
best
advocate.
advocate. And I know John is a fan of that. And if you look in the chat window, we've put the link in there. You can find it on the website.
John, we
Just
got a couple of
just one thing before we go to the questions that I'd like to say. Um, and also, I see there is a question here from Jeremy that came to me in private rather than to everybody. So maybe you can put it in again to everyone, Jeremy. There you go. I think these numbers are right, but I have to defer to my numbers guru here. But overall, whatever treatment you choose, radiation or surgery, the rate of recurrence in prostate cancer treatment is somewhere around 30 to 33%. And so I just want to put in context what you're seeing in focal therapy in the context of if you were to do radiation or if you were to do surgery. Is that right, John?
That is correct. You know, the recurrence rate overall of focal treatment is very competitive with the overall rate of recurrence for whole gland treatment. Now, let me clarify. An actuary doesn't look at it that way. An actuary does not look at averages. It's like, what is the average depth of the Mississippi River? Correct answer, 5 feet. Can you walk across the Mississippi River? No, you can't. So the average is really irrelevant. It is irrelevant. So the better question might be, for Gleason 6s, if you had the treatment, what would have a better outcome oncologically and functional outcomes? If you had a Gleason 8, Gleason 7, Gleason 10, by that risk strata. So when you look at whole gland treatment, if you have Gleason 6, one spot, plain vanilla, garden variety, you should be on active surveillance, obviously. Now, if you had whole gland treatment, the rate of recurrence would be extremely low, probably under 10%. But so what? You don't need it. You're going to have a lot of side effects. On the other hand, if you're Gleason 7 bilateral like me, high volume Gleason 7 bilateral, PSA under 10, the best studies, the best nomograms, the best meta-analyses revealed to me I'd have a 47% chance that whole gland treatment would work. That's it, only 47% for 10 years. Now that's biochemical recurrence, not real recurrence. But if I had biochemical recurrence, now I'd be on hormone treatment and a lot of other stuff that I don't want. So it's not good to have biochemical recurrence. Now, if you're Gleason, say 8, 9, or 10, those statistics are a lot worse. You're talking with men who have very high risk, and whether you do whole gland treatment, whether it's radiation surgery, the prognosis is not good. And if you need salvage treatment after whole gland treatment, the odds are that it will only work 50% of the time for 3 years, okay? And after 5 years, it'll only work 30% of the time. So you don't want to have salvage treatment after whole gland treatment. That's the worst. It's unlikely to work, and you can get side effects on top of side effects. Make sense?
John, so we have a whole list of questions for you.
Great.
Thank you so much. This is awesome. One of the questions is, did you look at Tulsa Pro for BPH? Is that a treatment for BPH?
Well, it's a great question. Tulsa Pro is good for prostates up to 250 cc's. That covers almost every BPH situation. So in theory, the technology can hit the entire prostate, including very, very large prostates. Now, they've never done a trial on BPH for Tulsa. Never. They're doing a trial right now as we speak in Germany. So in Europe, they're looking at that trial. They're also doing a trial for salvage treatment. So that'll be interesting. And actually those trials are being headed up in Finland, as I recall. So that's really kind of the leading edge center of excellence. Also, if you're looking for TULSA-PRO, the most have been done actually in Germany. So if someone wants to have it, look into it. In this country, it's doing currently at 4 centers. That's it, only 4 centers. And one center has done about 40, another center has done 23 as of this week. And the other 2 are small also. Now they'll be rolling it out at different locations, but it's only at 4 centers with very few patients. And it's only been done on whole gland in this country. No information on BPH, none. I've asked the experts, the scientists, you know, the people who make the device, the doctors, the clinicians. Great question. I've got a patient right now with 150 cc prostate, bad BPH. He also has a Gleason 9. So typically Gleason 9, according to Dr. Schultz, would be, you know, do your brachytherapy, do your external beam, and do your hormone treatment, you know, or something similar. But in this guy's situation, what do you do with 150 cc prostate? That is customized treatment. So he's working with Dr. Schultz and others to try to wrap his head around what's best for him. But BPH should work with TULSA-PRO.
Thank you. The next question, I think you might have answered this, but how do the recurrence rates you show for focal therapy compare to surgery or radiation?
You know, I'd say they're at least comparable, and people just have a hard time believing that. You know, researchers and doctors were brought up in medical school for years studying the paradigm that works. I've got to cure them. So they really have a hard time mentally changing the paradigm. So, you know, MRIs came out. A lot of doctors didn't believe in MRIs. You know, a lot of doctors don't believe in focal. Now, they've got some good reasons. I get it. But the outcomes in trials and in practice are very, very good for focal treatment.
I'm not 100% sure what this question is, but it says, is focal therapy an involvement with extracapsular involvement? I guess that could be, yeah.
That's another good question. And one way I'd answer it is, the laser can go through the capsule like a knife through butter. You know, it doesn't slow down. That capsule is like a paper thin little tissue. It doesn't even slow down. TULSA-PRO can go through that tissue. HIFU can go through that tissue. So just going through the capsule is not a bad mistake. On the other hand, it might even be deliberate. You know, it might be that it's a bad location and they deliberately go outside to take some margin into the lymph nodes. You know, what you never, never, never want to do is hit the rectum. If laser hits the rectum, huge mistake, can't go there. Now you could take out one nerve bundle on one side, not a big deal. It may be, it's necessary, it's a bad location. It doesn't matter what energy source you use. If you destroy all of the DNA in that nerve bundle, it will never come back. If you just give it a headache, it might come back in 6, 12, 18 months. So, you know, there's no perfect answer to that, but, you know, for me, I would be very concerned if I had any location that's outside the capsule or very, very, very close bulging, and I'd get second opinions. I'd really take a good look, because it might be better to do something more traditional, including, you know, radiation of the pelvis or even a lymph node dissection. But you need great imaging. You need to see where the stuff is. You can't just make it up.
Okay, thank you for that. I think that answered Jeremy, your next question as well. So Jim Schrade asked, what does in-bore actually mean?
Great, and I appreciate that. Don't be hesitant to ask any questions tonight. If you don't understand me, if you disagree, just ask them. I'm happy. In-bore means the patient is inside that MRI machine. They can do the procedure while the patient is inside the machine. Now, you can do biopsies, and that's great. Boy, you see that suspicious area? The guy's inside the machine. You put it in crosshairs. You look at it from this plane. You put in a needle right through the center. You put it through another plane. You look through another plane, put in 3 needles. dead center, you're going to get a lot of cancer. You're going to hit, if there's any pattern 4, you're going to hit it. Any pattern 5, you're going to hit it. On the other hand, if you're off by 2, 3, 4, 5 millimeters, you got a problem. It may miss the highest, Gleason score. It also may totally whiff and totally miss the lesion. So you really want to use in-bore, real-time imaging using just the MRI machine. Now, the problem is it's really hard to find that. It's very hard. So the next best thing is fusion guidance. What that means, they take a really good image of the prostate, really nice quality MRI image. Then they import it, they download it to the ultrasound. The ultrasound is real time, but it's importing an old image. Now the software alone, just by importing it, can be off from 2 millimeters to 7 millimeters. That's a co-registration error. You could be the best urologist in the world. You can think you're hitting dead center using your fusion biopsy, and you could be off by 5, 6, 7 millimeters and totally whiff. So fusion's not bad, but go with a guy who does a lot of fusion biopsies. He will put in multiple needles in a little bit different angle, a little bit different location. So he will deliberately, understanding that he could not be going through the center, do good enough. So, a purist would say, always do in-bore. The truth is, a good fusion biopsy is perfectly fine. What you don't want to do is just a trust biopsy. It can be called a blind biopsy, systematic. That has a 25% chance of missing clinically significant lesions. So the debate goes on now, do I need targeted? Do I need targeted plus, systematic? What do I need? And that's evolving. Over time, hopefully we won't need any biopsies. That's the goal. But that's not here yet.
Thank you for that. This next question was mine. So can focal therapy work if, let's say, you have 5 or 6 cores that were positive, but only one was 3+4, and that can you do the focal therapy just on one core and leave the other ones and do active surveillance on those as a sort of stopgap? Does that make sense? That's
a great question. And you're talking about something called an index lesion. And Elliot and you and Southern knows, there's a theory that if you've got one bad lesion, you can just treat that one bad lesion. The other lesions are just satellite. They're harmless. They're not going to go anywhere. They never metastasize. They'll never progress. Forget it. Just do the index lesion. That's a theory. Now, there's some pretty good trials, and a lot of doctors in the world believe in that. In the UK, Mark Emberton is one of the great doctors in the world, one of the great, focal doctors in the world. And over in the UK and other places, they believe in the index lesion theory. But there have been some other studies done that say you had the index lesion and you had other satellite lesions. And what it found is after you destroyed the index lesion, the satellite lesions became the index lesion. They progressed, got larger, caused problems, metastasized. So in my opinion, I'm conservative. So I don't treat just the index lesion. I had bilateral lesions, and I said to the doctor, I know we could treat just the index lesion, blah, 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 but would it be a problem? And I know I might have more side effects, but just treat all 3 lesions. He said, yeah, sure, we can do that. Okay? Yes. So you can't treat just one, and there's no science that tells you the right answer, but you're trading up. The more tissue you treat, the better oncologic outcomes, the worse the side effects. On laser, Dr. Feller found that average figure he was getting, that 23% plus 4%, that's an average over 10 years. What Feller found is in the early days, he was taking a smaller margin, and he was getting worse oncologic outcomes and better functional outcomes. Feller changed his methodology. He realized that his MRI machine couldn't see the little extensions coming out of what the MRI showed him. And so instead of taking a 1 or 2 millimeter margin, he started taking 3, 5, 7, 8 millimeter margins where possible. So now he's getting better oncologic outcomes and slightly worse functional outcomes. It's a trade-off, and have that conversation with your doctor. Your doctor doesn't know your goals. You know, some men worry a lot about ED. Some men haven't worried about ED for the last 5 years. They don't care. They care about not having to wear diapers the rest of their life. So, you know, that's where talk to the doctor, ask a lot of questions, but share your goals. Some approaches are better than others, depending on your goals. Make sense?
That does. Thank you. The next, can we, I guess we can, are you okay if we keep asking questions? We've got a lot of, well, we have about 3 or 4 more, I think.
I'm in your good hands.
Excellent. So the next question was, my only choice for focal therapy seems to be cryo due to coverage. Given that my cancer is on one side, I was told it had a better side effect profile than radiation or surgery. Is that right?
Well, first of all, as everyone here knows, always, always, always get a good MP-MRI. That just isn't a 3T MRI. That's a really good reader. So before you make any treatment decision, make sure you know the location. Patients need to know the location. Unfortunately, a lot of doctors don't worry about location as much as I worry about it. So get a really good MRI. And if you know that it's on one side, you know, really you could do cryo on one side. Now, my only other hint is go to a doctor who's really good at cryo. There's a guy down in Florida. He's done 850 of these. He does a lot of these. Dr. Tom Palasic at Duke does a lot of cryotherapy. He's really, really good. So go to someone, you know, hopefully in your hometown, but in my opinion, if you could travel to someone really good, I would do that. And then focal cryo would be a hemigland probably, might be the right answer. Now, if it's in the wrong location, for example, it's right near a nerve bundle, cryo is going to be very difficult to control. You're probably going to have ED. So location matters when you're doing focal. On the other hand, if it's way away from the nerve bundle, there's a good chance he can treat it, have a great oncologic outcome, and not have side effects that are that bad if you have the right cryo doctor. Some cryo doctors now are starting to use, you know, fusion guidance. You know, they're using some really creative approaches too.
Thank you. I think this question is actually directed to you. What made AS not an option? High percentage, 3+4, high PSA density, etc. I guess that, yeah.
Great question. You know, I really wanted active surveillance. I really wanted that. You know, I'm not dumb. First, do no harm, okay? And so in my situation, that was really what I was trying for. But, you know, I called some academic medical centers and I talked to their intake nurse and I talked to the person who was very knowledgeable. You know, I know the people who run surveillance programs in Canada, at Johns Hopkins and around. And so I kind of got their input. But, you know, what they said was not as important as what I thought. You know, I'll own the decision. I listen to everybody, but I'll own the decision. My thought process was I could probably stand it for 2 or 3 or 4 years. I wouldn't worry. I wouldn't be worried about it. I'd sleep at night. The problem is these 3 spots didn't just happen overnight. If we're one spot, I'd say, well, you know, who cares? 2 spots on one side, not a big deal. But when it's on both sides, 3 significant spots, in my way of thinking, this is likely to keep growing. Even though I have a healthy diet, healthy lifestyle, I do all the right stuff, it's likely to keep growing. Maybe it's genetics, who knows? But to me, if I treated it in 2014 with focal, the odds were in my favor of having a great outcome. I was worried if I waited 3, 4 years, it might be more complex and focal or any procedure wouldn't have a great outcome. So to me, I bit the bullet, had it treated with that thinking in mind. And I know it wouldn't kill me. It's not going to metastasize anytime soon. My survival's fine. But how can I treat it in a way, handle it in a way to minimize my long-term side effects? So, I'll never be wearing diapers. I can play golf every day, whatever.
Thank you, John. The next question came from Gene. Are you familiar with gold nanoparticles?
Yes, I am. Gold nanoparticles are a brilliant idea. They're very new. And Dr. Art Rastenhead is kind of the genius behind it. Art is a urologist by training, but he knows imaging as well as anybody. Art went to the NIH for many years and studied how to do MRIs. And so when you go to an AUA or RSNA or any of these clinical conferences, you'll see Art Rastenhead doing the training on how to do MRIs. He's that good. So Art came up with the idea, maybe we can use something that you stick in the arm and it travels around the body and it ends up in certain places. It'll end up here, 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 but it will end up wherever there's prostate cancer. Nobody knows exactly why. Now, this theory has been and then they'll just treat it with a low energy light source. The low energy light source activates and they kind of explode, but it's very precise, very, very precise. And so someone came up with this idea many years ago and it was called VTP. Sloan Kettering liked the idea. Sloan Kettering did a lot of testing. It's also known as 2CAD. So 2CAD VTP has been around for a long time, but the outcomes are just mediocre. Last February, I was asked to present testimony at the FDA meeting evaluating 2CAD. I was brought in to Silver Springs, Maryland to testify before the FDA. Interestingly, the FDA were great. They were brilliant. They were insightful. They asked a lot of questions. I love them. And when I talked about a patient's position, they listened to every word. And they said, Mr. Fortin, thank you so much. Dr. Patrick Walsh, Dr. Siddiqui, really luminaries in the field said, we get it. And frankly, we're really disappointed we don't have focal treatment today. We're really disappointed. We've been struggling for years and outcomes and how can you do a clinical trial that's valid and, but we're getting our arms around it. And, we need to approve focal treatment soon. But still, 2CAD was not great. Their results are not great. But Art Rastenhead and people at an organization, and it's an organization in Houston, Texas, came up with this, and they figured out how to use gold nanoparticles with an activated light source, but their technology is different. Gold nanoparticles are not a drug. It's not regulated as a drug by the FDA. It's regulated as a treatment. So that's one difference. Also, nanoparticles are uniform in size. Every single one is uniform in size. They're teeny, 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 tiny. So they get into the capillaries. When you get into the capillaries with uniform particles, they go straight to the prostate cancer. That was a theory, the hypothesis. So they tried a trial of about 50 men, and the 50 men had extremely good outcomes. Now, usually this type of trial is just trying to see if they don't kill someone. It's a very easy bar. If no one dies, and if no one has, a level 4 toxicity, a level 5 toxicity means the guy died. If they didn't have a serious adverse event, hey, that's good enough, it's feasible. Now let's go ahead and do a real study. So they did the feasibility study and they expected kind of mediocre results. What they found was it had great oncologic outcomes. It also had great functional outcomes, the side effects. And so you can look at Euro Today. I interviewed Dr. Rastenhead. So go to Euro Today. I'll shamelessly promote Euro Today. Go to Euro Today and, inside there's a search box. Look at gold nanoparticles Rastenhead, and you'll see a video of him where I interview him for 20 minutes. And Art just kind of walks through the technology, how it works, the outcome, side effects. So now they're in phase 2. Phase 2 has 3 locations, in the New York area with Rastenhead's new hospital, one in Houston, and a third, which is in the University of Michigan. And that's a very credible investigator there. He was trained at NIH also, Arvin George. And now they're going to expand it. They're going to add Mayo Clinic and a few other locations. So all of a sudden, they're looking at 7 locations, but it's not just a feasibility study. It's called a pivotal trial. If you get through the pivotal trial, then they'll take it to the FDA for approval for prostate cancer. The gold nanoparticles people believe it needs to be proven for prostate cancer. Some of the other modalities, they don't care about approval for prostate cancer. They just want to prove to treat the prostate. So it's a different philosophy in getting it approved. But gold nanoparticles, I'll put it this way, you have to be a certain Gleason score. You can't have any prior treatment. You might be eligible for the trial. You might get in it free and try it out. Having said that, it's only been tried on 50 men. So if you're a risk taker, go for it. I'll say this also. If you want to be a pioneer, go for it. Now, I kid with my doctor friends. So Dr. Rastan did, you want to be a pioneer? You do realize that pioneers get shot. But gold nanoparticles has a lot of potential. I do not own any stock in it. I do not receive any compensation. I don't receive any money from anybody except reimbursement on my travel expenses. I don't want to jeopardize my objectivity. Any other questions?
We have one last question. If you can hear me, I'm having, looks like computer glitchy problems. Does focal work if there's no identifiable lesion on the MRI?
That's a great question. The answer is no. You need a target. And, in theory, maybe gold nanoparticles, ultimately you don't need to see it, but you need a target. You need to see exactly where the suspicious area is. You need to biopsy it. It needs to be confirmed as prostate cancer. Then it's worth doing. That's my opinion. But that's also consensus. When I went to the focal treatment meeting in February, all the best focal treatment doctors and researchers in the world were there, over 200. I was the only patient. I was the only reporter. And so they asked that question. I got consensus opinion. Overwhelmingly, they believe you have to see it to treat it. And these are the guys who believe in focal. But they said, no, if you can't see it and it's not confirmed, don't go there.
Thank you so much.
We've
I
had some
think
great
that's
questions.
all of. I think that was the whole list of questions for you. There was one question I think posted to all the other members. So if anybody wants to look in the chat box, there was a question from Jeremy to everyone. Howard, do you want to take over?
Just to thank John for an excellent program. There's a lot to absorb there, and I'm really glad that we're making a video of this so that other people who couldn't be here tonight will have a chance to hear it. But that's about it. I don't know if John has any summary that he wants to make, or do you just want to say goodbye?
Well, really, I just want to thank you all for listening, being open to new ideas. I hope this was interesting to you. Don't worry about all the details. If you do need treatment, make sure you go up the learning curve, ask questions and questions and questions, get the best doctor, and just, make an informed decision. So great seeing you. Also, if any of you would like to contact me at any time at no charge, I'll be happy to be your coach. You can get my contact information from Elliot or AnCan or whoever, and they'll give you my telephone number and email. And I'd be happy to get on the phone with you and we could just chat and just kind of brainstorm. I won't give any clinical advice, but we can brainstorm about the questions you should be asking your doctors, where you could find good doctors, and if I could help clarify any, factual actuarial information, I'd be happy to do that. And also I'll tell you what books I think are best reading. And I'll urge everyone to go to support groups. Support groups are great. Thank you so much.
Thank you. And Jake, if you want to stop it, I think we're done. And we can, and we'll hang around to